And now it's time for the most awaited panel discussion of the day. I now call upon Dr. Dushyant Mandlik, sir, Senior Consultant at HCG Asta Cancer Center, for moderating a panel on parotid tumors. Our panelists are Dr. Jyoti Dabolkar, ma'am. Ma'am is presently Senior Consultant in ENT Department at HN Reliance Foundation Hospital and Research Center, Mumbai. Ma'am has served as the head of the Department ENT at KM Hospital and GS Medical College. She is one of the founding pillars of FHNO, Foundation of Head and Neck Oncology, and has served as its president. I call upon Dr. Pareen Patel, sir, Senior Consultant in the Department of Head and Neck Oncology, SCG Asta Cancer Center. Dr. Paras Khanna. Dr. Khanna is a surgical oncologist presently based out of Jammu. Dr. Shubha Kanare, ma'am, Head of Department of Oncopathology at HCG Asta Cancer Center. Dr. Dhanesha Goyal, sir. Sir is a plastic and onco-reconstructive microsurgeon at HCG Asta Cancer Center, Ahmedabad. Dr. Maitri Gandhi, ma'am, Consultant Radiation Oncologist at HCG Cancer Center, Ahmedabad. Dr. Dushyant Bansali, sir. Sir is a Senior Surgical Oncologist at Maringo Sims Hospital, Ahmedabad. Dr. Shivam Pandya, Consultant Surgical Oncologist at Shelby Hospitals, Ahmedabad. And Dr. Ankita Dembla, Consultant Radiologist at Sterling Hospitals, Kandida.
This is about parotid tumors. We discussed a lot. We dissected out the parotid to the last molecule or last fragment of the nerve. And most of the questions of the panel are answered, but still I will like to go through the panel because it's a case-based discussion. So, welcome all again to our new center. I was perplexed that how should I put my panelists. So I have put them the way we use their role in diagnosis and treating the parotid tumor. So definitely we have radiologist who guides us firsthand inside the parotid. We have surgical oncologists who are the main drivers of the parotid tumor surgeries or management. We have plastic team, we have oncopathologist Dr. Shubha, and we have our radiation oncologist also. As we have discussed, it's a rare neoplasm. The guidelines are there, but very few. If the tumors are low stage, well localized, you get an excellent 5-year overall survival rate. But as the tumor progresses or there is a distant metastasis, the 5-year survival rate decreases. And as Dr. Shubha rightly told us that there is a difference between the biology of the tumors in the aggressiveness, which also dictates the management and outcome. But as a lot of there is in between the lines, the wisdom is still required, and there is where the experience comes, there is where the sixth sense of the clinician comes. There are many questions which are answered and there are many questions which are unanswered. We will try to look into them, and let us go to our first case. She is a 43-year-old female patient, walked into our OPD in November 2022 with left-sided cheek swelling for 4 months. She went to an outside clinician who did an excision biopsy before 12 days. She came with a suture wound and edema around that wound. Examination revealed that facial nerve functions are normal and there are no palpable lymphadenopathy. So my first question to the surgical oncologist here, that this excision biopsy, how many of you will endorse an excision biopsy in a facial parotid tumor?
What was the imaging? There is no imaging.
No imaging.
So that's the biggest mistake.
Okay.
Nobody should ever do anything without a simple imaging like a USG.
So it's a very open, clear-cut message to all that do not venture or do not do a stuff like excision biopsy, even if had an imaging. Ma'am.
And in this case, now what is required is a CT scan.
So, if there was an imaging, ma'am, let us say we have a CT scan or MRI, will you go for an excision biopsy?
No.
No.
There is no question.
So the first
Then you would have
investigation.
taken a decision about the extent of the surgery, whether it is in a superficial lobe, more benign.
So for diagnosis, no excision biopsy. I think that is clear.
Absolutely.
Absolutely.
A core biopsy importance Anil already highlighted, so that's a different thing.
So,
This is excision.
so we had this excision biopsy report, and Dr. Shubda reported this, and there are gradings of this carcinoma. It came like a mucoepidermoid carcinoma of intermediate grade. Dr. Shubda, we would like to know from you that how you grade these tumors and what is this grading system?
Yeah, actually, see, CAP gives the choice of 3 grading systems. One is Brandwin, then AFIP and MSKCC. If we grade by Brandwin and AFIP, most of the tumors end up being intermediate. So I use a MSKCC and I use mitosis and necrosis to discern between whether it's a low grade or high grade. I do give this information in the report, whether there is a solid component, whether there is lymphovascular invasion, whether there is perineural spread. But I don't use these criteria to discern the grade, because most of the times there will be intracystic component which is more than 25%. There will be some nuclear ATPR. So most of the times if you use these 2 grading systems, most of the tumors will fall in intermediate grade.
So Dr. Pareen, my question to you, that this patient has come to you with an intermediate grade mucoepidermal carcinoma. As madam says, most of the time you end up in intermediate grade. What will be your next step for this patient? You do not have a baseline investigation. You have a patient who is just 12 days post biopsy with an edema and sutured wound. How would you like to go ahead?
I would like to investigate her, and I will like to go for MRI, contrast MRI, and would like to see for a residual disease present or not. And as such, she has underwent that enucleation. So after MRI, we will decide the further plan of the management.
So Dr. Paras, what is your choice of investigation, CT or MRI?
An MRI, contrast and MRI, but prior to that, probably speaking with the operating surgeon would make us a little wiser while interpreting the imaging also.
So operating surgeon had no idea, he did an excision biopsy.
I agree, but I think as a matter of habit of investigating cases which are operated outside, like we take a pathology review or an imaging review, it doesn't hurt anybody by speaking with the operating
So
surgeon.
there was no intention of cure or treatment or excision, it wasn't just a biopsy.
So
Right,
if that
yeah.
information is available with us now, we just go ahead with a contrast enhanced MRI and assess how we can proceed further.
So definitely as, yeah. Yeah, Dr. Dev.
Yeah, it's very nice to have an MRI or some imaging, but we should not forget that if surgery is just done 2 weeks or 3 weeks or 4 weeks, MRI is going to be biased. You follow, it is very important for us to realize that a prior intervention in the area is not going to give you the correct MRI, guidelines. So it is, with that in mind, you should ask for an MRI, because he is just been operated. Not only MRI, even if you do a PET scan also, it will be biased. So immediately to do MRI within 2 weeks, 3 weeks of surgery, I don't know how much information that is going to give and how much reliable it will be for you to decide the management.
So Dr. Ankita, the patient comes to you, is sent to you, definitely a radiology is required because it gives better localization, detection of additional masses, any nodal disease, better guidance for FNR core, involvement of other structures. But here is a patient 2 weeks post excision biopsy with edema and sutured scar. How good or how comfortable you will be to read that MRI?
Sir, for the basic tumor, MRI might not be useful because the patient has been recently operated. But as we know, this mucoepidermoid carcinoma has higher chances of nodal mets. So MRI can help us in guiding where are the mets and how big they are. Like what is the status of the metastatic nature, and depending on.
So there are two problems now we have. One is primary and one is metastasis. So you say that you will be able to identify the metastasis better but not able to comment excellently on primary.
Yes, because the thing is, sir, if we do post-contrast MRI in such cases, even the lesion will enhance if any remnant is there, and post-operative changes are also, there is also high likelihood that they will also enhance. So we cannot differentiate exactly where is the the residual lesion and where is the what is the post-operative change.
So how many from the panel will defer their radiological investigation for a few more days? Any from the audience? So we have around 3, 4, 5 hands which says that they will defer their management. Yes, sir. Yeah.
Yeah, so when you say that you will defer and when you say that you will jump in, what is the time frame which is important?
Yeah.
And that's the reason why I need to investigate this patient. As Ankita said very correctly, that it will not give me the information for the primary surgical area, but I need to know other things. If there is a huge perineural invasion, she will be able to tell me. If there are gross nodes positive, she will be able to tell me. So looking at other things are more important so that I can decide whether I can wait or not. To wait for a mucoepidermoid carcinoma for few more weeks will depend on this investigation.
So this is not a decision in isolation. It's very well said that you are going to have all the information as a new baseline which you have right now. You may not act on those informations, or you may not immediately jump for the surgery, but you need to have some information to compare your future investigations at least. So, yeah. Yes, Deepa, yeah. Yeah. We do not have any evidence of it is complete or not. It's a multiple pieces. It's not in toto.
Mic is not working.
Yeah, we can hear you.
You would wait for around 4 to 6 weeks for the, I think on MRI, maybe Ankita can correct me if I'm wrong, at least in 4 weeks she'll be able to give us information on the primary side. So waiting another 2 weeks for the inflammatory component to settle down and her giving us information may be prudent. It's a mucoepidermoid carcinoma, it's not a squamous carcinoma, will rapidly change in 2 weeks' time. So I would actually wait and defer my investigation for maybe another 2 to 3 weeks. The patient also is more settled in the frame of mind and the the edema settles down. And a one-stop investigation at that point of time will help me decide what to do further.
So Deepa, what will be your counseling to the patient? Patient is worried. She is a young female, says that I am having cancer. You are not doing anything and just sitting on me. What will be your counseling to the patient?
So I'll tell her that even if I have to do anything, if I go in when you are in an acute phase of inflammation, and if I suppose they make a decision based on an erroneous judgment, the chance of you having facial injury or any complications during surgery is much higher. I'd rather wait for the acute inflammation to settle down so that we have a much better plan of action and we can do things more carefully where there will be less chances of injury. So I think with this, most of our patients would understand and are eligible, more compliant to follow up. Your counseling and your talking is very important at this point.
I think Dr. DeCruz has almost 40% of his cases recurrent.
So I'll tell you what I'll tell them. I'll tell the young beautiful girl, आपकी सर्जरी अधूरी है, आपको निश्चित सर्जरी लगेगी फिर, बट आज 6 हफ्ते के बाद 3 महीने के बाद I will decide. आज करूं because you have cancer, you're not going to die. Kosub, if a mucoepidermoid grows to inoperable proportions and metastasizes in 3 weeks, even if you operate that patient, the patient is dead.
You read me wrong. I didn't say that after 3 weeks it will grow. What I say is I want to know today If there are gross lymph nodes and gross things, I will not wait.
Gross you will know.
So that
It's
is
not
what I want to
bad.
know.
It's not bad.
It's not primary I am
All of
assessing.
us don't work in centers where patients are very affording. I sometimes even just do a plain ultrasound to see the neck, even in a TX tongue lesion. If I'm suspecting that there's a node, I'll do an ultrasound, but I'll do the scan after a couple of weeks.
Yeah, so
And
at least
then
you need
Ankita-
imaging. You need
Yeah,
to assess
yeah,
this patient.
yeah. So it's
you just
always
can't just tell.
So definitely this was explained to the patient, and Deepa made a great point that why she is not operating this patient, because the chances of injuring the patient rather than curing the patients are higher in current scenario. And Dr. Dicruz says that I will wait for investigations or at least MRI, but as the patient was jumpy, she went on the next day to get an MRI done outside and came to our OPD again on the next OPD day with this MRI report. Dr. Ankita, can you just tell us what this MRI says?
Sir, on MRI, I see an enhancing component, enhancing soft tissue area is there, which is present in mesenteric space, and it is, yeah, and there is a small defect is present in the mesenteric space, that's it. All I can say is this much only, so I'll be the conclusion can be like, the conclusion will be that it could be post-operative changes more likely than chances of a residual lesion.
So she came with this MRI, post-excision cavity in intersuperior aspect of superficial left parotid gland, no lesion, no abnormally enlarged lymph nodes, no lymphadenopathy. Young female. From the panel, Dushyant bhai, how you will like to go ahead with this patient?
So with the present report and the inflammatory changes being seen, and we are still not able to decide whether there is a residual tumor or any involvement of node, so we should definitely wait for a few months for the inflammation to settle down and then review the case again and then decide for the surgery.
So you will go clinically?
Yes, see, we already have MRI report now.
Okay.
And on base of that, as Ankita said, Dr. Ankita, that we cannot make out whether there is any disease or any, I would say, inflammatory reaction, and we can see a pocket of air pocket, which is the defect from where the biopsy was done. So we should wait and again review after say 1 month or 1.5 months and again get a MRI done if it's possible, and then take a call.
Sir, you will endorse that?
Yes, sir. I'll say that it's good to wait for 2 weeks to 2 to 4 weeks. Let the inflammation settle, get a repeat imaging, because now we have a baseline imaging already. So
what will be the next imaging time? 2 to 3 weeks? 3 months? 3 months. 3 months? 3 months, okay.
I said 3 months.
Okay. Anybody less than 3 months?
That's a healing of any tissue.
Okay. So if clinically fine, you are not seeing any abnormal things, patient is clinically doing okay, you will wait for 3 months. Farin, you want to tell something?
I would like to investigate, I would first like to say, I would go for a Dicruz sir, because she will definitely require surgery. And I would like to repeat her scan after 1.5 to 2 months, whether patient is comfortable, whatever time early. And after 1.5 to 2 months, we will again compare the scans and then counsel regarding the surgery. Because young female patient is quite apprehensive as inadequate surgery. She will definitely require a superficial parotidectomy.
So the patient came, as we said, that patient was doing fine clinically. We examined the patient for a month and every month clinically, and she was doing okay. So at the 3rd month or around March 2023, we again went for an MRI. Yeah, Abhishek, you want to tell something?
Yes, so before that, can I just want to know the opinion. Can we suggest a via media? Why not do an ultrasonography guided FNAC? Also look for the neck nodes via ultrasonography.
So there is no lesion, Abhishek, here. There is no lesion. It is just a cavity.
Yeah. Forget this case, but let's say a freshly operated case where an MRI would obviously show post-treatment changes.
This is just post-treatment changes. There is no lesion here. It's just a cavity.
Right.
So here we are in March and we have this MRI. Dr. Ankita, can you just educate us on this MRI?
So here we see that there is a hypointense lesion is present in anterior aspect of superficial lobe of left parotid gland, and the margins of the lesion are irregular, and there is possible involvement of adjoining subcutaneous fat. This lesion is showing a heterogeneous post-contrast enhancement. So the findings are more in favor of a residual lesion.
So how many of audience and panel will one like to put a needle, will two like to wait, and three like to go for surgery? Needle, putting a needle, FNAC?
But for what?
For this nodule?
But you already know this. This is.
We already have histological.
Is it a fibrosis or is it a nodule or no? Okay, so you will not put a needle. Fine. You will go for surgery? How many for surgery up front?
Yes.
Okay, and how many will wait? Okay, so sir, why you will wait?
Please define the time. I think. Please define.
So let me see the MRI first. Say the MRI first. It was saying 12 by 9 by 7 millimeter nodule there, and it's a minimally delayed enhancing nodule. And there is a slight prominent enhancement of the rest of the parotid. It was because the duct was obstructed and there was an inflammation there. It's 3 months post your excision biopsy. Rest everything is fine. Yes sir, why you will wait?
So as Anil said, there is no rush in surgery. Right now, I am not seeing anything. This nodule probably will go away also. So I'll wait for another. I will counsel her.
So you will put a needle or no?
No need of needle.
No need to put needle. Okay, so you will counsel. Yes, Dr. Dev.
No, but if clinical examination tells me that all the previous inflammation, edema, irregularity of the superficial is gone and the skin has become more or less normal, and because of the previous knowledge that I am dealing with a parotid mucoepidermal carcinoma which was excised inadequately, surgery is preeminent, and if the skin is normal, I don't think that by waiting another, because I have committed, she has undergone, as Anil told, आपकी surgery अभी अधूरी है, तो आधा अधूरा तो नहीं छोड़ सकते ना, तो we have to operate her, and now the skin is normal, I'll operate, I'll not wait.
So this was a scar on the skin.
Yeah, there was a scar on the skin.
Anteriorly. This was not.
This is just under the scar.
Right.
Okay, so how many from the panel will operate?
So where can you locate it? Like you don't have clinical picture of
Here it is. Here it is. It's purely smooth. There is nothing on the scar. Well-healed scar. How many of you will operate? Surgeons.
Yes.
So out of 5, 3 will operate, 2 will observe. Okay.
What is the MRI T2 of that nodule? Is it hypointense or hyperintense?
So I have only this images right now with me.
So we have a radiologist, I
So
think she can comment.
So this is a T2 image, isn't it?
It is hypo, right?
Right, it is.
It is hypo, and
Yeah.
importantly, in the previous scan, nothing was there, right?
Yeah.
And something appeared in this scan, so that is suspicious.
Plus it is irregular.
So our MRI specialist says that this is a suspicious nodule, right?
So when
the patient comes with us with a suspicious nodule and says that my MRI says that I'm going here cancer again. So you will tell them to wait, not putting the needle, Dr. Kaustubh, or you will put needle at least?
No, if my radiologist says that it's suspicious, I will put a needle. If I am waiting, I'll put a needle. If I am doing surgery, I don't need to put a needle.
Okay. So as we rightly said about FNSE, let us go to this FNSE of this nodule. We went for an FNSE of this nodule and it came like Milan 3, atypical cells of undetermined significance. Dr. Subda, how will you guide us for the further management?
First and foremost, there should have been a biopsy because there is a history of previous surgery. So the effect of
There
surgery...
was a biopsy. You can't excise and biopsy that.
Instead of FNSE, core biopsy. What I am trying to
It's
say...
a very small nodule, 12
Then at
millimeter.
least a cell block should have been made instead of making slides.
This was reported by you only actually.
I did not make the slides. Reported by me is okay, but Jignesh should have made a cell block instead of slides because of the simple reason that effect of surgery will produce foamy histiocytes, so as the mucoepidermoid carcinoma will have mucocytes. So if we do a simple pan-cytokeratin on the cell block, it will tell us whether these are histiocytes or carcinoma cells. So if you have to put a needle, in such cases the radiologist has to be warned ki don't make slides, put in formalin.
Okay.
Yeah, I'm sorry, I have to just say one sentence. Listen, this is an inadequately excised intermediate grade mucoepidermoid carcinoma. Why are we wanting to do a biopsy? I want to question that. I think it is utterly unnecessary. We know it is an inadequately done operation. We have to operate.
If you are operating, you don't need any biopsy. You don't need any FNSE.
So if you are operating...
You don't need to wait. By waiting, what are you going to
So Dr. Kaustubh, you have this atypical cells of undetermined Milan 3. Now what you will do? Now you will operate or not?
I'll do surgery.
You will do surgery? Okay. But now there is a twist in this thing. The patient says, I am absolutely fine, okay. You don't know that I am having cancer or not and you want to operate. Deepa said that there are chances of injuring my facial. I don't want to wait. I don't want to get operated. And she waited for 1 more year. And this is MRI of February 2024. Absolutely fine, nothing there. But now there are certain areas which are picking up here. And there is something here also. Yeah, Ankita. Patient waited, patient didn't want for surgery. Patient came after 1 year, he was on regular follow-up, clinical, and after 1 year, this is an MRI done because we suggested that if you don't do anything, at least get an yearly investigations done. So Ankita, can you tell us? This was the previous lesion.
Yeah.
This is something else coming up here. This is something else coming up
Yeah,
here.
so the lesion which was primarily present in on like MAT scan, that is more or less of the same size, but we see there is another lesion which is seen involving deep lobe, part of deep lobe of left parotid gland.
Okay.
Plus we are seeing lymph nodes also present in left cervical region, left level 2.
So how much you think that it's suspicious? There is some necrosis in between cystic
the
area.
bigger lesion, the bigger node is having some degree of necrosis, as in the enhancement pattern is heterogeneous. Plus with the presence of these two lesions, it is more in favor that these are metastatic deposits.
Okay. So now the patient is frightened, says that I just want to get operated. Everybody is saying that my cancer is coming back and now it has increased and I will like to get operated. So definitely now surgery, patient also doesn't want observation. What will be the extent of your resection? I think we have made it clear through the panel, but anybody from the panel will do less than a total parotid in this patient? No.
Sir,
Yeah. Yes, Gurpreet, yeah. Okay, so we did an MRI of the patient. We did an CT thorax, which is normal. So metastatic workup is done. Still, you want to do a PET CT?
Okay. Sir, sorry to interrupt. here this side.
Yeah.
Can
Yes,
I
Sakshi.
ask a question which is a step before
Yeah, why not?
the
Yes,
finding
yes.
which we just came to know?
Yes.
When we have a result of a SUMP or atypia, what madam was telling, is there any recommendation depending on the size, and I'm referring to the ESMO recommendations, depending on the size of the tumor, if it is more than 15 millimeters, we go ahead and do a wide needle biopsy or a core biopsy, what madam
It
suggested.
was 12 millimeter.
If it is less than that, then we do MRI and follow-up. So are we correct in, my thought is that if it was less than 15 millimeters, are we correct in observing that?
So it was less than 12. It was Milan
Less than
3.
15, yes.
Right? And we observed. Even if we say patient that we will operate, patient says, I don't want surgery right
So
now.
my question was that if we get any SUMP and FNAC, would the panel recommend we look at the size and decide whether we do the core or we observe?
Surgeons. If it is less than 15 millimeter, which was right now, is it's going to change any of your management? I think we were pretty clear that we will operate. We will
not in this
not observe, right?
Not in this case, yeah.
Okay. So, Dr. Shubhda, I think you elegantly told about role of frozen section in your lecture, the role of neuromonitoring, and I think we visited this papers during previous talks also. We went for a total parotidectomy. It was a lot of fibrosis there. As a policy, we usually use neuromonitoring in all this kind of patients who have dense fibrosis being encountered. And we did a left level 2 lymph node dissection, as Dr. D. Cruz rightly said. We sent it for frozen section also and found it negative for the malignancy. This is what our final histopathology came. A 10 by 6 by 5 millimeter nodule, which was the nodule which MRI was telling, which was subcutaneous, came out to be a mucoepidermoid carcinoma, superficial lobe, intermediate grade, and there was some extragranular soft tissue involved. The deep lobe was not having any tumor. There was no tumor in deep lobe. All the margins were free, all the lots intraparotid and outside the parotid at level 2 were also negative. So
Extragranular soft tissue involved.
no, the thing which was seen on MRI as a suspicious second lesion in deep lobe came out to be no malignancy. No, that is 10 by 6 by 5, that's only.
There was a big lesion seen in deep.
Yeah,
So what was
but the deep lobe came negative. So surgeons, again questions to you. Were you right doing your total parotidectomy in this patient, or retrospectively you think that you would have done a superficial parotidectomy?
Sorry, there was just one thing, because that deep lobe was such an unexpected red herring. I would have frankly done a biopsy of the deep lobe, because I would not have expected a small thing in the anterior part of the superficial lobe to present with something in the deep lobe. So why did we not do that?
So it's a two-cut biopsy of the deep lobe which you will like to have before
Because if it is
going-
totally clear, there is no reason to do this kind of an operation.
Vijay, this is in retrospect. If we find a mucoepidermoid carcinoma patient who is inadequately operated, we have advised surgery, patient has waited, and then she comes up with this kind of lesions in parotid. You have to, you feel that you have to do a complete surgery. Now, it can be a
primary
lymph
had
node.
hardly increased.
It can be a lymph node also. Primary is still there.
No,
it
no.
can be a lymph node also. You don't know.
I agree, but all I'm saying is,
So keeping
how
that,
would a biopsy of that hurt?
But that biopsy, it's not 100%, right?
So Dr.
Any
Shubhda,
biopsy is not 100%.
I think I will rather ask Dr. Shubhda that if we have a deep lobe biopsy before the surgery, how you will be able to guide us regarding doing a deep lobectomy or total parotidectomy or doing a superficial? preoperative true cut biopsy of the deep lobe which was suspicious having
Yeah,
a malignancy on MRI,
Yes, yes.
how good you will be able to
See,
guide
first and
us?
foremost, I have said 0 out of 2 lymph nodes in the deep lobe.
Yeah.
So there were 2 nodes which were found in the deep lobe.
Yeah.
Means those lesions could have been the nodes to start with. And the answer to your question is, if a biopsy is done, we can definitely discern whether it's normal salivary gland or mucoepidermoid carcinoma in a biopsy. That is a very simple.
The residue was just under the skin. Subcutaneous only.
So this actually proves our point, those who are in favor of not waiting and operating this patient, we should have operated, because I cannot explain what happened to the deep lobe, what was seen on MRI, but certainly we would have done a total parotidectomy. I would not have left behind the deep lobe.
Even at that time, first surgery?
No, first surgery we would not have done it. But at least I would have done a completion surgery at the end of 3 months of observation, and when you have repeated an MRI and there was a residual suspicious disease seen on MRI.
Patient said no, yeah. Yes, sir. Yes, sir.
No. This is a master course, and it is actually masters who are going to tell the junior people. It is not meant for masters. Now, whatever is happening for the past 15 minutes is only for between me, Kaustubh, Shabar, Rajan Toprani. It does not hold water for the people who are sitting there. For the people who are sitting there, this person was inadequately operated. She required surgery revision at that time. I will put on my paper, you need surgery. India is a democratic country. She can opt or she cannot do. That's a different story. But me as a consultant would tell her that you need surgery. Your surgery is imminent. I have enough proof under the whatever biopsy you have brought, whether it is in 1 block or 100 pieces, you need revision surgery. As soon as the local conditions are favorable, I will operate. I will not do anything more than this. No needle, no core. She gets operated, fine. She doesn't get operated, I have written it down. She needs surgery. Don't get involved in this intellectual whatever is going on. It does not apply to you. To you, common thing apply. She needs to be operated.
There is no doubt that she needs to be
Message was very
operated.
clear. After 3 months, she was operated. She was to be operated. Patient refused.
That's a different story.
Yeah. Then the case goes beyond that. That when
So
she-
now,
after 1 year.
yeah.
What?
So the question now is superficial parotidectomy for this lesion, or with the suspicion of having malignancy in deep lobe, total lobectomy. We are all having a retrospective wisdom here.
Sir.
I will rather, yes.
Yeah,
Absolutely,
exactly.
Absolutely.
We would do
agree.
what-
I think Jayesh
we
made
would
the
do
right
what you
point.
did.
So
Jayesh
this is
made the
right
right
which is
point.
done. This
Sir,
is perfectly
retrospectively,
proper.
if we would have done PET, would it?
No.
No, the inflammation will also pick it up.
No, but after
After
1
3
year,
months.
the 1 year scan which showed that deep lobe lesion and few nodes. The nodes are small.
Let us say that
And-
that PAT scan also picks up the lesion, picks up the inflammation.
See, what happens is that
Right.
even the mucoepidermoid carcinoma, if the mucoid element is more, the PET will not pick up.
It's a low grade.
Positive PET has no value. Negative PET.
So I think the point made very clear. You will not like to regret leaving behind a mucoepidermoid carcinoma in the deep lobe while you are actually going for this surgery second time. So you can't answer that lady again that you have done a half-hearted surgery, and again you will go for third time to remove anything in the deep lobe. You can't.
I think the best thing is to tell her that you are fortunate.
Yeah.
And she really is fortunate that her tumor has not spread to the deep lobe or the nodes.
So it's a T3N0, a small tumor but subcutaneously going. Yeah. Dr. Shubhda reported it's normal. I trust her. Yeah. So any adjuvant? I think everybody. No, is anybody for adjuvant or nobody for adjuvant or no adjuvant? Radiation oncologist, I think. Let us ask by
What I feel
T3N0. It's a residual tumor.
I would give radiation.
Okay.
The reason is that it is extraglandular.
Yeah.
so basically that means
Though the tumor is less, it's a recurrent tumor which is extraglandular. I would
So how many
suggest-
for radiation? Hands up. How many against radiation? Okay, others will refer the patient. Fine. Okay. So yeah, your call.
being it
We send the
extra-
patient to you.
Yeah, so being it extraglandular soft tissue involved, I would preferably would like to go for radiation. But one thing would hold me back in giving radiation is that it was the same nodule which was seen before 1 year also. It has not increased in size and it is of the same size even now, which shows that it is a very non-aggressive and a very low-grade tumor. So I would like to discuss with the surgeons how comfortable are they in giving, in observing, or you prefer treating.
So I will counsel the patient. We have sent it to you. You have to decide that what is the advantage of giving radiation versus waiting. You have to weigh and give the verdict to
So
the
the
patient.
patient has waited for 1 year and she has undergone surgery again. So I would not, like to wait her again. And being a young patient, I would more prefer in favor of giving radiation.
My reason
Yes, sir.
for giving radiation would be also because you have done a very complete thorough surgery. Now if she recurs, her nerves are going to go.
Yes, sir.
Anterior lesion, posteriorly there is no tumor. So what kind of radiation you will give to that lesion? Like it will be below the skin. So are you considering electron or you are going to give?
No, so we can definitely give photon. We can, if required on the skin, we can use a bolus also. So that is an option with the photons.
Yeah,
because,
Dr. Dev.
Because
No.
with
Again, we are at crossroads. There are fixed standards for giving post-operative adjuvant radiation therapy. The guidelines are extremely clear. There are 7 points. I may not remember all the 7. Large tumors, tumors with fixity of the skin or a deeper structure, inadequate margin, recurrent tumors, R plus resection, and nodes. I must have left it. There is no scope of you thinking or not thinking. All this setting, whether you like, whether you don't like, whether patient agrees, patient doesn't agree, they must be told post-operative adjuvant treatment. There is no such thing that patient was waiting for 2 years, nothing happened to her. That is different story. We are not debating science. Science says in this setting, she needs post-operative adjuvant therapy. How, what dose, that radiation therapist knows, but there is no scope of intellectual deliberation. Yeah, no, residual tumor, that yeah, so this is a residual disease and you are operated second time, she receives post-operative adjuvant treatment. No, this is the residual, they have left over the tumor. So this is, this is a case for radiation therapy, no? Or you are disagreeing? That's why radiation, no?
So I think
I personally feel that in the setting of disease, this is a residual disease or recurrent disease, this is debatable. You have operated on a patient which had inadequate surgery, that means it was R plus resection, you must give post-operative adjuvant treatment.
Yes, Dr. Sarin.
Are we revising because of inadequate first treatment, or are we revising because of recurrence despite complete and adequate treatment? There are two different scenarios. Just for this case, if we had revised this operation at 3 months and you had the same 12 mm residual and you got great margins when you revised it, you won't radiate. I think it's low grade, I'm guessing. This is
Intermediate grade mucoepidermal carcinoma.
This is Brandwin 2, just 2 points. That's low grade, I think. But anyway, irrespective.
And extraglandular involvement.
I think
Intermediate.
So my take on extraglandular is, when you say extraglandular and you look at literature, You're looking at a big basket of tumors. Most of them are very big, which are extraglandular. If this is a small anterior focus in the accessory lobe and you get great margins around it, I probably wouldn't radiate this patient.
Okay, so we have two schools of thought. Few says that few. No, it was after she was attached with us. So okay, let us go ahead. I think there is no clear cut mandate on you radiate or no, don't radiate, but I think most of us will like to radiate this patient. The patient has relapsed or recurred or is a residual. It's a big question, but I think it's an inadequate surgery which we are going to clear now with the margins, and the patient definitely received the radiation, and yeah, it was under the scar, so the scar was revised. Yeah. They would have gone for superficial. Because at that time MRI was okay.
Superficial surgery with the revision of the scar.
What would have happened if you had done a superficial parotidectomy and after a year's MRI shows this kind of
Core biopsy.
Core biopsy. I think we will commit with this in the next panel. She is still under follow-up.
Then image guided core biopsy would be done.
So let us go for the second case. Very interesting case. 19-year-old male patient. Incidentally detected swelling in left infraauricular region for 2 months back. Just a swelling. Size has remained stable over the 2 years and no other complaints. Facial nerve is fine. Everything is good. Yeah. You get biased. Yeah. So on examination is a 3x3 firm swelling, hard mass below and behind the left pinna, restricted mobility, outer skin is free, facial nerve is intact, intraoral, neck, everything is fine, okay, right? Patient has come with an outside CT scan. Dr. Ankita, this is the CT scan plates with which the patient came. Can you read the scan and enlighten us more? Is this the right scan, or what you are reading from the scan is okay, or what is your inference?
Sir, we see a lesion which has both solid and cystic component, and there is involvement of left lobe. But the CT scan will not be just required. We need MRI too.
Is this the right sequence?
No.
This is not even contrast.
There is no contrast.
So it's a non-contrast CT scan with which the patient came, and this was the inference of the CT scan, around 3 centimeter lesion in posterior part of superficial lobe of parotid, bulging into the deep lobe, few small level 2 and 3 lymph nodes, indeterminate. Any further investigation required? What investigation? MRI? Okay, you will like for MRI. The patient also came with an FNSE. This was the FNSE smear saying that probably a Wardin's tumor, right? So 19-year male patient. Yeah, it was hard. So surgeons, this is the patient which came with a non-contrast CT scan with an outside FNAC saying Wardin's tumor, 19-year-old patient with intact facial and hard mass under the ear. What next you will like to do?
I would like to do the contrast MRI and also like to do a USG guided core needle biopsy.
Okay, review the slides. So we got a review of the slide, low-grade mucoepidermoid carcinoma. Okay. Okay, and we went for an MRI also. Dr. Ankita, this was the contrast and his MRI.
This.
To add to that, the patient was destined for a parotidectomy before they came to the clinic, and patient said that no, I don't want to get operated here, I would like to have the second opinion. So in the all probabilities, he would have been operated before our consultation in some other clinic. So this is the MRI. Can you read this MRI?
Sir, in this case, there is a heterogeneously enhancing lesion is present involving left parotid gland. There is involvement of deep lobe. There are few non-enhancing enhancing necrotic areas present within the lesion. Also, we see few lymph nodes. They are present in bilateral cervical regions. But I think the MSAD of the node present at left level 2 is less than 10, so it could be reactive.
So this is the lesion, a 3 centimeter lesion, necrosis involving superficial and deep lobe, abutment of left mastoid with encasement of left ECA wrapping around the left condyle and left ramus of mandible with multiple centimetric lymph nodes at level 2, 3 and 4, and the facial nerve is intact. What next?
So I want to ask Subda ma'am.
Yeah.
In the previous talk, she told that on FNSC, she would be able to tell if the grade is high grade or something. So
नहीं आपने नहीं किया. So for a change, she has not reported this. She said that if Parin, she very clearly said that if you ask a single grading question, she will shoot at me and the panel will be over.
No, see, mucoepidermoid carcinoma on FNAC, unless it's a grade 3 ATPR, you will not be, and when it's a grade 3 ATPR, you will not be able to diagnose as a mucoepidermoid.
So what, surgeons? Yes, Darshan bhai.
So we have to go for total paroidectomy, and as the nerve is normal and functioning and it is a low grade mucoepidermoid carcinoma, we should preserve the nerve, and there is an encasement of left external carotid artery which can always be removed along with the specimen.
So you are satisfied with this review of FNAC or you would like to have something else?
You can go for a core biopsy if
you can go for or you will go for?
We should go for a core
How many
biopsy.
of our you will go for core biopsy before venturing into this patient where you are almost going to sacrifice your facial? It is encasing mastoid, it is encasing condyle. There are high chances that when you enter, you might not be able to save your facial. Yes, sir.
It is important that you realize that here on imaging, they have told that this tumor is encasing external carotid artery. So when you are doing anything other than FNAC, core or something like that, it must be done very carefully. This patient must be admitted in the hospital. You should be ready to intervene. You should have surgeons standing when they are doing it, because it is possible that the carotid artery is pushed up rather than going down, and you should be little careful in advising core biopsy for this lesion where the radiologist has told unequivocally that the external carotid artery is encased.
It's a guidance core, no? It's a guidance core.
Guided biopsy.
No, that's what I'm telling, that you need to have a guided core biopsy and you should be prepared. Yeah.
So, I think most of you will go for the ultrasound guided true cut biopsy of the patient. We have reviewed and we have seen this paper in previous lectures also, that core biopsy is totally safe and definitely gives you better yield. Now we are going to operate this 19-year-old patient. So,
Let me just give a so
yeah.
This is basically our case. So this case presented to us with a non-contrast CD and an FNA, which we have already discussed. Seen not in head and neck. Let's be very clear, this wasn't seen in our OPD. We got the slide reviewed. That was a differential of a low-grade mucoepidermoid carcinoma. The MRI is right in front of us. We think there is a possibility we might have to sacrifice it now. We are yet to operate this patient. He is posted next week. we have planned for a true cut biopsy. The true cut biopsy has been done today. We are still not with the results. But the point is, with the imaging findings that we have, our counseling was that the chance of sacrificing the nerve is very high. That's why we got the FNA from the lymph nodes as well, just to be sure that it came out to be reactive. Now the problem is in the counseling that for a 19-year-old boy with a normal facial nerve with such an extensive disease and with no definitive evidence of malignancy pre-operatively, how do you counsel this patient that you would sacrifice his nerve if need be? So that's why we have undergone core biopsy. So that's why the question.
I think since morning, I think we have been discussing. No.
So just a review of FNA.
It's a review of FNA, it's not core.
So don't go on the low grade or the high grade lymphopedomoid. There is a big malignancy sitting there. Chance of sacrificing the nerve is very high for the proper clearance of the disease.
So I think I would like to rephrase my questions that how many of you have seen a low-grade mucoepidermal carcinoma having this picture on MRI? Raise your hands. How many of you have seen low-grade mucoepidermal carcinoma with this MRI picture with intact facial nerve? Exactly. So our diagnosis is not confirmed. So that's to confirm our diagnosis, we should go for a true cut biopsy, core biopsy.
Dushyant, so this is a malignancy for sure. The extent of resection that we have been discussing since morning is dependent on the site of the tumor. If you require to do a total parotidectomy for this patient, be it. You should do a total parotidectomy for
Be it an aggressive malignancy.
So whether to sacrifice the nerve or not will depend on table because the nerve is functioning. Now if you have to make inroads into the dissection, you must sacrifice the nerve.
Rajendra, can I make a point? So you don't have the images. But we've seen the
Let me, this is for the junior. If you have nerve functioning normally, okay. No. No. If you no. I am commenting on the previous comment. If the nerve is functioning normally clinically, it doesn't tell you anything more. It can still be encased by the tumor.
Yeah.
And in that case, you will have to sacrifice. So in my opinion, when you take up these kinds of patients, whether they are 19-year-old or 90-year-old, they must be counseled that it is possible, though your nerve is normal, at present clinically, on table, low grade, high grade, this time BJP, Janata Party, Congress, you will be prepared for sacrifice and you should be ready for that. You should have a team of people who will get a sural nerve or whatever it may be. You cannot go on the age and the symptom.
The context in this, the question is to do a core needle biopsy or not. The reason is, if you are not sure about the FNAC report, you need a second FNAC or a core, and core is preferred. So that's why if the FNAC report is dicey, you should do a core needle biopsy. If there is a firm report on FNAC, whether low grade, high grade doesn't matter. But if it is positive for malignancy, you don't need a core. But if the FNAC is dicey, you must do a biopsy again, and that is preferably core biopsy in this situation. I think, but they say that it was not very conclusive.
So I think let us go ahead. We will skip this. I will skip to the next of the next slides, and then we'll like to go for this. This is a patient where there is a high-grade mucoepidermal carcinoma of the left-sided parotid gland, and my question will be to Dr. Dhanush, our reconstructive surgeon. So we had to sacrifice our facial here, as you can see here, and we had stumps of our facial artery here. How you would like to approach this patient?
So being a reconstructive surgeon or resection surgeon, I would like to go for the, first of all, to assess the defect in the form of the nerve damage or loss and or skin and soft tissue or volume loss. So it's clear cut, we can see that I think a big skin loss from the cranial caudal to anteroposterior, and there is a nerve loss. There is, we can see the nerve end and the distal end of the supplying nerve is there. So I would prefer free tissue transfer, because it gives me a liberty to harvest the simultaneously harvest the like a free radially forearm flap, then the same hand antecubital nerve. So I would like to reconstruct with that nerve. I will put the nerve graft, cable graft, and then reconstruct. At least I prefer to reconstruct, to give reanimation to two muscles, orbicularis oculi and orbicularis oris, which gives the patient a smile, at least make the smile, and then eye movement.
So when all the nerves are sacrificed, let us say all the branches from the main trunk or from the bifurcation have been sacrificed, will you like to reconstruct all the nerves given a choice, or you will just select few?
I would like to select few because I seen that defect is more, and I think
but you have your cable, you have abundant of nerve available. Why you are not reconstructing all the branches?
Yeah, first of all, I would like to check the intraoperatively that nerve endings are there to supply that particular that muscle, like 5 ends.
All the distant nerves are functioning.
Both, all nerves better. My question is that is there any?
So I think the point here which I will like to make is that many times what happens that you have your greater auricular nerve with you. You have all the 5 nerves sacrificed, and with that small segment you just try to reconstruct the ophthalmic branch or the superior branch, and you don't reconstruct the buccal branch, just not to say harvest the sural nerve or any other nerve conduits. It is better to reconstruct all the branches because functionally it is very much important. Even the buccal branch is very important, because the deformity which happens with the buccal branch is that the buccinator or the chewing muscle doesn't function well if it is sacrificed. So though visually the upper branches are more important, functionally the lower branches are also same important. So we did a radial forearm, Dhanush did a radial forearm with nerve graft, and this is 11 months after that. So I think I will skip this radiation planning and everything. Proton, I think we just touched upon. Maitri, you would like to tell anything about the proton, where you will use it and where you will not use it? What is the to go for indication for proton right now in salivary glands?
So basically proton we can consider only if we are dealing with a re-radiation case where we feel that the constraints could not be met. Okay. Otherwise we can easily do it with IMRT which we are having. Only re-RT with the dose constraints where we cannot meet them. Otherwise there is no specific indication for proton as such.
So currently not specifically indicated. I think very few select indications of it, and I think we covered 3 cases, 2 good and 1 partially, and I leave you here where my confusion is guided with a clear sense of purpose to do good for patients, and our purpose remains solid and unified to do better for our patients. Thank you.